Hello, this is Dr. Scott Berman. I'm the psychiatrist who consults to Holcomb Behavioral Health Systems in Allentown and Eastern Pennsylvania. In this talk, I'll be covering serious mental illness, in particular schizophrenia, bipolar disorder, and major depressive disorder. Schizophrenia is a chronic neuropsychiatric illness. To have schizophrenia, you must have at least 2 of the 5 symptoms below: hallucinations, delusions, disorganized speech, disorganized behavior or catatonia, and negative symptoms, loss of motivation or emotional response. In particular, hallucinations are usually auditory or visual in schizophrenia, and delusions can be paranoid, grandiose, or otherwise. Schizophrenia also requires occupational or social dysfunction, continuous symptoms for at least 6 months, and other diagnoses having been excluded. It cannot be due to a medical condition and is not part of a developmental disorder such as autism. Schizophrenia has multiple symptom clusters. The ones we usually think about are hallucinations, delusions, disorganized speech, thought, or behavior. However, there are very significant negative symptoms. These include alogia, or not talking, affective flattening, where you see very little emotion from the person, avolition, where they are not motivated, asociality, where they do not interact with others, and anhedonia, where they do not derive any pleasure from daily activities. The third cluster are cognitive symptoms, which include memory deficits, attentional problems, executive dysfunction, and many others. There are also usually common mood symptoms, including depression, hopelessness, anxiety, agitation, suicidality, and hostility. Anosognosia is the loss of insight, such that many schizophrenic patients will not realize that they are sick. Finally, schizophrenic patients often have many medical illnesses, including substance abuse, smoking, metabolic syndrome, which includes high blood sugar, high cholesterol, high blood pressure, and other physical illnesses. The negative symptoms and cognitive symptoms account for most of the chronic disability, much more so than the hallucinations. And smoking, substance abuse, and high blood pressure, high cholesterol, diabetes, stroke, and heart disease account for about 25 years of lost life per person, more so than people in the general population. Positive symptoms include auditory hallucinations, which are the most common, hearing voices, in particular derogatory voices saying bad things about the person, or command hallucinations, sometimes to do dangerous or self-harming things. Visual hallucinations are not uncommon, and tactile hallucinations are uncommon, but they can go along with other paranoid delusions, such as feeling that someone is putting electric shocks into the patient. Tactile hallucinations are more common in alcoholism and other illnesses. Olfactory hallucinations, or unusual smells, are unusual unless paired with a delusion, such as I smell bad, or someone put poison gas in my apartment. Psychosis, some key points. Psychosis is a severe loss of reality testing, such as hallucinations or delusions. It is not unique to schizophrenia. Hallucinations and delusions can occur in major depression, bipolar disorder, substance use, neurological conditions, including Parkinson's disease, dementia, epilepsy. Medications can cause psychosis. Don't confuse psychosis with schizophrenia. Negative symptoms: alogia, not talking, affective flattening, no real expressions, avolition, no motivation or initiation of activity, asociality, social withdrawal, anhedonia, inability to feel pleasure. Primary negative symptoms are caused by the schizophrenia itself. Secondary negative symptoms can be caused by either a primary symptom, for example, if somebody's paranoid, they won't go out socially, or a negative symptom can be caused by treatment, such as loss of pleasure from the dulling of meds. Negative symptoms and cognitive symptoms are the major causes of disability in schizophrenia and the hardest ones to treat. They are the least responsive to current medications. Cognitive symptoms include lower IQ, impaired attention, impaired working memory, which is the ability to hold and manipulate data in your mind, verbal fluency, verbal learning, and memory. In this case, the encoding is intact. That is, the person may be able to learn a list of 10 words, and he may be able to recognize them if given a list of many words, and those words are in that list. But recalling them spontaneously will be impaired. The executive function will be impaired, which is planning, handling complex situations, adapting to change. These deficits, especially verbal learning and executive function, correspond to difficulty with social, interpersonal, and occupational functioning. Comorbidity, a high frequent substance abuse, especially nicotine in patients with schizophrenia, high rate of illness from cardiovascular metabolic disease, obesity, high cholesterol, high blood pressure, high blood sugar, diabetes, and smoking. Some key facts about schizophrenia. It affects about 1% of the population globally. Male equals to female in prevalence. In the men, it starts in the teens to early 20s. In women, it starts in early to late 20s. About 10% of patients will commit suicide, and overall the prognosis is poor. Many patients will stabilize, but only 10 to 20% ever recover fully. Causes: unknown. Before birth, first trimester complications such as bleeding during pregnancy, gestational diabetes, emergency C-section, asphyxia, and low birth weight are associated with later schizophrenia, but probably don't cause it. Second trimester complications, infection, excess stress, may double the risk for later schizophrenia. Genetic risk. If you have a first-degree relative, that is a parent, child, or sibling schizophrenic, you will have a 10% risk. 3% if you have a second-degree relative, such as a grandparent or a cousin. Identical twins from the same zygote, if one is schizophrenic, there's 48 to 50% chance the other will be schizophrenic, which reminds us again that this is not entirely genetic, or both twins would always be schizophrenic. Dizygotic twins from two different fertilized eggs have a 13% risk, and there's a 40% risk of schizophrenia if both your parents are schizophrenic. Environmental stressors linked to schizophrenia include childhood trauma, minority status, ethnicity, residence in urban area, and social isolation. Treatment of schizophrenia. Antipsychotic medications are currently the only credible treatment. They can stabilize and help remission, but cannot cure. Treatment without medications is never recommended. Relapse off of medications is very high, practically 100%, and practically inevitable. Comprehensive psychosocial treatment, along with medications, provides better outcomes. Schizophrenia treatment. Psychotherapy. Individual therapy includes supportive counseling, personal therapy, social skills therapy, vocational sheltered employment. Group therapy can work on interaction and social skills. Cognitive behavior therapy includes helping with compliance or adherence. In the last several years, an important research protocol has shown that therapy plus medication will give better results. It's called RAISE, or Recovery After Initial Schizophrenic Episode, developed as a team protocol for community clinics to improve care in first episode psychosis. It's more effective than medication alone. It can be implemented in any clinic that works as a team and commits to coordinated care. It provides better quality of life outcomes. The 4 parts of the RAISE, or Recovery After Initial Schizophrenic Episode Early Treatment Protocol ETP program, are a psychopharmacology protocol that comes in a manual, family education and support, individual resilience training, and supported employment or education. There are free manuals for all 4 components at raiseetp.org and shorter ones at practiceinnovations.org. The treatment manuals have guidelines and handouts you can use freely. They are absolutely useful both for therapists and case managers. It can help you standardize your treatment and focus in on critical issues. Major depression and bipolar disorder. Major depression has only depressive episodes. Bipolar disorder must have at least one manic or hypomanic episode. After one manic or hypomanic episode, a patient is always considered bipolar after this, although they will spend most of their time in depression or back in remission and little time in mania. Because of this, and because many bipolar patients present with depression, a lot of bipolar patients are not properly diagnosed for years. Major depression requires 2 weeks of low mood or loss of pleasure and 5 out of 9 of the following symptoms: change in sleep, either more or less, diminished interest in pleasurable activities that previously had been done, feelings of guilt or worthlessness, impaired energy, impaired concentration, appetite, which may go up or down, psychomotor retardation, which can be extreme slowing or agitation, and suicidal thoughts or plans. If you look at the first letter, it's SIGECAPS or SIG-E-CAPS. In the prescription, we write SIG, prescribe, the name of the medicine, E, and CAPS, capsules. So SIG-E-CAPS is a standard psychiatric mnemonic to remember the 9 symptoms. Bipolar disorder, mania criteria. To have a manic episode, you must have at least 1 week of elevated mood or irritable mood and increased activity, or for hypomania, 4 days and 3 out of the 7 symptoms below, or 4 if the mood is irritable. And again, the first thing to notice is somebody whose mood changes every 5 minutes may be moody, but they're not meeting the criteria for mania. Manic criteria include distractibility, which is not terribly specific because we see it in ADHD and anxiety, impulsivity or unusual behaviors such as spending sprees, hypersexuality, impulsive drug and alcohol use, unplanned travel, grandiosity, which can become psychotic, such as delusions of being a king or a god, flight of ideas, where many different ideas kind of pour out at once from the patient and they're hard to follow, increased activity, hyperproductive, starting many projects, sleep not needed. This is not insomnia where the person can't fall asleep but wants to. This is a person who stops trying to go to sleep because they've got so much energy, and talking fast. And again, if you look at the first letter of this, D-I-G-F-A-S-T, dig fast, is our mnemonic for mania criteria. Bipolar type 1 episode of full mania, 7 days or more, and inability to function during that time. Bipolar 2, hypomania, can be as short as 4 days, but not shorter, and even if it goes longer, the patient can usually function socially and vocationally during the mania. Subtypes of depression, and these apply to people who are bipolar and in depression, or unipolar major depression. Melancholic depression includes loss of all pleasure and 3 of the 5 symptoms. Worst mood in the morning, which we call diurnal variation, early awakening, significant weight loss, signs of agitation, excessive or inappropriate guilt. Atypical depression looks a lot different. This includes mood reactivity, people who perk up to pleasurable stimuli but at baseline are depressed, and 2 of the 4 symptoms below: hypersomnia, increased sleep, hyperphagia, increased appetite, leaden paralysis, or feelings of physical heaviness of the body and limbs, rejection sensitivity, extreme sensitivity to rejection or criticism. Psychotic depression includes hallucinations or delusions, usually negative ones. Seasonal affective disorder, or now with depression with seasonal features, includes a pattern where in the winter months when the days are shorter, typically the person is not only more depressed but often sleeps more, eats more, is more irritable and less productive, such as the picture of somebody who's hibernating. Mixed features, difficult to measure, but this is somebody with depression with at least 3 manic symptoms, or mania with at least 3 depressive symptoms. And persistent depressive disorder, what we used to call dysthymia, chronic depression of 2 or more years. Why does it sometimes matter? First of all, bipolar patients respond differently to medications than major depression. That is, over and over again, we see that patients with bipolar disorder, even though their depression looks exactly the same as patients with major depression, have much less response to typical antidepressants. The overall data shows that it really doesn't help much for antidepressants, and although we used to be worried about the antidepressants causing cycling, they also don't harm very much, but they are not first line. Patients with psychotic features always need an antipsychotic as part of their regimen. And patients with atypical depression respond better to the old monoamine oxidase inhibitors, MAOIs, if SSRIs or serotonin drugs don't work. Signs of bipolar depression. If we want to understand bipolar versus unipolar depression, in people who most often come in depressed, as people tend not to come in manic-y, we need a careful past history of both manic and depressive episodes. We need a family history because family history of bipolar disorder helps tilt us towards manic depression for the patient. We need careful symptom checklists, including the IDS-30, or the Inventory of Depressive Symptoms 30 for depressive subtypes, the PHQ, or Patient Health Questionnaire 9 for depression, and the Mood Disorder Questionnaire for bipolar disorder. Now, the Mood Disorder Questionnaire has been in wide use for many years, but it's not particularly specific. That is, it will pick up a lot of positives, but it will also diagnose a lot of people as bipolar who are not. I've been using it in the clinic for the last several years. When I ask people what they mean by the questions, most often they do not have a cluster of bipolar symptoms, but simply random times when they have been irritable, angry, not needed sleep, and so forth. So I stopped using it because it just doesn't give enough historical background, and it's asking about the here and now. I've tried using several other questionnaires, and again, because of the difficulty of eliciting the past, unless the patient clearly remembers a mania, and also because of the number of people who've been told they're manic depressive based on a day or two of agitation or a night of not sleeping, we get a lot of false positives. So what's the lesson? You need to do all of these things to get a good idea of the diagnosis, and you still may be wrong, but at least you'll know what you're looking for. If they screen negative in the MDQ or other rating scales for bipolarity, it'll be pretty clear they're not bipolar, especially with this collaborative family history. If they screen positive, buyer beware. The screen may be wrong unless there's good other data to support it also. Clues to bipolar disorder. Early onset of mood symptoms, people who start before the age of 21. A family history of bipolar disorder. Psychotic symptoms. Poor response to antidepressant. Remember, we said the antidepressants don't work well in bipolar depression. Worsening or mania with antidepressants. Seasonal features. Postpartum depression. Many episodes and mixed features are all clues that the depression you're seeing is actually a bipolar disorder. Everyone is not bipolar. Symptoms that are not accurate for bipolar diagnosis: moodiness, agitation, irritability, insomnia, racing thoughts. In particular, racing thoughts are not accurate. If you ask carefully, some people have happy flight of ideas kind of racing thoughts, but most of the people we talk to have anxious, ruminative racing thoughts about problems they're having. Psychosis can be unipolar or bipolar depression. Rapid mood swings are not accurate for bipolar diagnosis unless each upswing lasts 4 days or longer. Conditions that can be misdiagnosed as bipolar. Borderline personality disorder famously has extremely erratic mood regulation. ADHD, a significant number of people with attention deficit have emotional dysregulation. That is, part of their frontal lobe that controls attention and concentration is not working properly, and a part of the frontal lobe that's right next to that part of the brain, which controls emotional regulation, is also not working well. Depression with anxious features can look manic-y. PTSD can look like somebody with extreme mood lability. Substance abuse can look like bipolar disorder, as can histrionic personality disorder, schizoaffective disorder, and many others. Bipolar, borderline, or both? One more time. Borderline personality diagnosis has 9 criteria. Intense and highly changeable moods with each episode lasting a few hours to a few days. Bipolar patients have moods that stay up or down for several days or longer. Inappropriate intense anger or problems controlling anger. Bipolar patients may be angry or irritable as part of a manic episode, but it's not a chronic personality trait. But borderline patients have impulsive and dangerous behavior such as spending sprees, unsafe sex, substance abuse, reckless driving, and binge eating. We can see these also, every one of these, in bipolar disorder, but these symptoms of bipolar patients tend to go along with a manic mood and are not happening intermittently and independent of mood. Borderline patients have recurring thoughts of suicide behaviors and also self-injurious and self-mutilating behaviors. Bipolar patients are most often suicidal during a depressive episode. It's not directed to in response to other people or in response to a breakup or a fight, and self-injurious, self-mutilation behaviors are not characteristic of bipolar disorder. Transient stress-related paranoid ideation or dissociation can be seen in borderline personality. Bipolar disorder, if it's psychotic, usually there's full-blown hallucinations and delusions during the mood episode. Going on, borderline patients have a pattern of intense and unstable relationships. Bipolar patients can have stable relationships outside of their mood episodes. Borderline patients have distorted, unstable self-image, not characteristic of bipolar patients. They have chronic feelings of emptiness, not characteristic of bipolar patients, and efforts to avoid real or imagined abandonment, again, not characteristic of bipolar patients. Bipolar patients have flight of ideas, not characteristic of borderline patients, talking fast, and no need for sleep, all not characteristic of borderline patients. Bipolar patients have grandiosity, while borderline patients have chronic distortion of both overvaluing and undervaluing themselves. Bipolar patients can be hyperproductive, not characteristic of borderline patients. Bipolar patients can be distractible, as can ADHD and anxiety patients. Borderline patients have more emotional ability. Irritability, moodiness, inconsistent behavior, insomnia are common to all human beings and not diagnostic of anything. Racing thoughts can be grandiose in mania or ruminative in depression and anxiety. Emotional dysregulation is seen in ADHD along with distractibility. So this all ends up being very confusing, especially in young adults, and especially because somebody can have ADHD and or bipolar disorder and or borderline personality disorder. However, it would be a mistake to give all three diagnoses just because there's a mishmash of symptoms and not enough time has gone by to do a good diagnostic evaluation over a number of months or years. Final notes on diagnosis. You need a collaborative family history. Talk to the family, and there's rating scales they can use. Use the rating scales. We talked about them. There's a McLean borderline personality scale, which I put on my multiple page screener. It will pop up in people who don't really pop up for bipolar disorder. The adult self-rating scale for ADHD. Give the patient mood charts. Every 30 days you can see if the mood's stable, up or down. And explain to the patient that ADHD, depression, bipolar disorder, borderline personality disorder will overlap. You may not really know the answer for a while. Pharmacologic management. Schizophrenia is antipsychotics plus or minus adjunctive medication. Bipolar disorder is a complex algorithm of mood stabilizers and antipsychotics. Major depression is antidepressants with augmenting agents if needed. Antipsychotics. The first generation, and the first one was thorazine or chlorpromazine. After that there was profenazine, haloperidol or Haldol, and many others. These medications treat psychosis and mania only. They do not help with mood. They have many neurological side effects. Second generation antipsychotics include the medicines listed here, and I gave you the generic name and the brand name for all 12. And here we have a chart where we see, based on which of the 12 you're looking at, you can treat psychosis, mania, a mixed manic depressive episode, bipolar depression, or be added on to help with major depression. You see that in particular, olanzapine, which is Zyprexa, quetiapine, which is Seroquel, and lorazepam, which is Latuda, all can help bipolar depression, and they're the only three medicines currently licensed for bipolar depression. Cariprazine, which is Vraylar, has been approved for mixed episodes, and it does have studies strongly supporting that it will help bipolar depression, just not yet approved. In addition, olanzapine, which is Zyprexa, quetiapine, which is Seroquel, and aripiprazole, which is Abilify, and brexpiprazole, which is Rexulti, can all be added to antidepressants to give a boosting effect in major depression. So, second generation antipsychotics have a much broader spectrum of usefulness. What kind of side effects do we get? Well, the ones we're watching for are weight gain, increased blood sugar, and increased lipids, which is cholesterol triglycerides, which together are the metabolic syndrome parameters. Sedation, dizziness, orthostasis, which is a drop in blood pressure when you stand up, akaesthesia, which is a feeling of motor restlessness, which can be very uncomfortable, incapacitating, and cause a patient to stop their medicine. High prolactin. This is important because if prolactin goes up, it will cause, in men and women, breast growth or gynecomastia, lactation, not having a period, reduced sex drive, and even bone loss. Finally, on the electrocardiogram, one of the little intervals is called the QT interval. An elevated QT can lead to dangerous arrhythmias and death, so we have to watch for that also. So all of these are things we look at across the whole class of 12 medications. But really, if you look carefully, many of these meds have nothing of any consequence for side effects in that area. So, for instance, in somebody where we need to avoid any weight gain, aripiprazole, asenapine, lorazepam would be very friendly. On the other hand, we also have to look at usefulness. Only olanzapine, quetiapine, and lorazepam will hit bipolar depression, and there we try to use lorazepam, which is Latuda, or quetiapine, which is Seroquel, before olanzapine, even though it's the most effective, because olanzapine has the most weight gain. Metabolic syndrome. Psychiatric patients, especially those with schizophrenia and bipolar disorder, have a higher rate of cardiovascular disease. This includes heart disease, stroke, and diabetes, which leads to vessel problems. Also have a higher rate of smoking, which also impairs blood vessel function. Again, we talked about second-generation antipsychotics leading to weight gain, higher sugar, higher lipids, and high blood pressure, which is called metabolic syndrome. Metabolic syndrome is something we measure in the office at the beginning and every several months in patients on antipsychotics. If a patient has a waist size more than 40 inches for a man or 35 inches for a woman, that counts as 1 point in scoring it. Body mass index can be calculated. It's weight over height times 703. And when you get past 29.9, you're in the obese range. Blood pressure, systolic greater than 140 or diastolic, lower number greater than 90. But there's just new guidelines from major American medical associations saying we need to aim lower. Fasting blood sugar over 99, good cholesterol, HDL, less than 40 in men or less than 50 in women, triglycerides greater than 150. For each of the 5 points that you get, add them up. If you score more than 3, you have metabolic syndrome. You get a point automatically if you're already on blood pressure meds, cholesterol meds, or diabetes meds. We also ask everybody if they smoke. It's not enough to measure, we need to intervene. For obesity, we recommend diet, exercise, referral to weight management, or bariatrics program, which can include gastric bypass surgery. And again, no surprise, for everything else, diet, exercise, and getting them back to their family doctor. Smoking, we offer cessation help, including Zyban, Chantix, and nicotine replacement therapy. It's perfectly possible to get patients with serious mental illness off of cigarettes, and a review of data for the last few years says Chantix is safe even in serious mental illness. There's no significant number of people who are becoming agitated or suicidal, and the risk of smoking in terms of mortality and chronic illness is always going to be higher than the risk of the medications. It's the highest risk activity that our patients have. Bipolar disorder, medication. There are standardized algorithms based on several different organizations, including the British Association of Psychopharmacology and the Harvard Medicine Algorithm Project. They're based on the phase whether the patient is manic, mixed, depressed, or in maintenance treatment. In bipolar depression, again, it's with Tuda, Seroquel, or a combination of Prozac and Zyprexa, which is olanzapine fluoxetine, OFC combination. Second line, we would add lithium, valproic acid, or carbamazepine, or try lamotrigine, which is Lamictal. Third line are some more esoteric things such as pramipexole, modafinil, or adding an antidepressant, bupropion or a serotonin reuptake inhibitor. We never give an antidepressant alone to a patient with bipolar disorder. Well, I would say you can never say never. Everybody has a few patients who insist that they're fine only with an antidepressant, refuse everything else. Some of them do fine. Last line is electroconvulsive therapy or a combination of all the meds above. This is one of the hardest conditions to treat, bipolar depression, in all of psychiatry. Mania is easier to treat. Any antipsychotic and or lithium or valproic acid will treat mania. And then we do combinations. Maintenance. Lithium is primary and it's been around the longest, or valproic acid, or carbamazepine, Tegretol. An antipsychotic, in fact, aripiprazole injectable, Abilify Maintainer, is approved for this. And the only qualm is that antipsychotics over many years can cause tardive dyskinesia, which is an incurable neurological movement disorder. Most patients require at least 2 meds to maintain mood stability. Major depression. The first line is going to be an SSRI, Zoloft, Prozac, Lexapro, Exapex, Luvox, or Wellbutrin, bupropion, or Vibrate, or Trintellix, or Remeron. 3 out of 10 patients will get a full remission from a first antidepressant. 4 out of 10 will get a response, that is 50% reduction in symptoms on a rating scale. Response without remission is not enough because of residual disability and higher risk of relapse. 3 out of 10 will get no response at all to a first antidepressant. Second line treatments, a complex mishmash with no clear algorithms, though very elegant studies have been done, including the STAR-D trial. But we're still left with the same choices in clinical practice. Optimize, which is to increase the dose as high as we can. Augment by adding a second-generation antipsychotic, or lithium, or thyroid, or buspar, or others. Adding a second antidepressant that works differently, such as adding bupropion or mirtazapine Remeron to an SSRI, and switching to an antidepressant that works differently. There's some people who think that switching has very low usefulness. We don't have enough large studies and long enough studies to give us batting order for each of these things and which meds to use in what order. So common sense and past experience of the patient in terms of what has worked for them prevails, as does avoidance of side effects they would find particularly objectionable. Adding a second antidepressant is relatively straightforward. Augmenting with a second-generation antipsychotic is probably the most common and the most effective that we have right now. Switching makes the most sense when a patient has been on a medicine for a number of weeks at a good dose and has had zero effect. If they had a partial effect, you don't want to lose that partial effect, so then you're going to optimize, augment, or add. We tend not to switch unless there's a total treatment failure or a very significant side effect, which then makes it reasonable to switch and move on to the next three over and over again. We also look at newer versus older antidepressants, and we tend to start with these less toxic medicines such as serotonin reuptake inhibitors, Wellbutrin, Vibrant, and so forth, and old-fashioned tricyclic antidepressants, some of which can be very powerful, and even monoamine oxidase inhibitors, which can be exceptionally powerful, though hard to work with in terms of side effects and special diet, should still be used. Here's the depression treatment curve. If here's normal, and then we go into depression in the acute phase. Again, a response is when the person goes from horrible to just miserable. So if their PHQ score, which could be up to 27 at the highest, goes from 26 to 13, they've got a response. The problem with going from 26 to 13 is still moderately severe depression. So they're not out of the woods, they don't feel well. If they get worse again in the first several months while we're just starting, it's a relapse. When we get to remission, if they get worse during the first 3 or 4 months of continuation treatment, it's a relapse. If they get 4 to 6 months of full remission, we consider them in recovery, and then the next episode is considered a recurrent episode. And this is important because patients who have multiple recurrences are then going to be advised to have lifetime maintenance medication because their relapse rate is high. We explain that to them, that just like a blood pressure patient who can't stop antihypertensive medicines, or a diabetic who must always use insulin, they will always need a medicine to prevent recurrences. In particular, interpersonal therapy deals with their ability to be effective with other people in a way that helps them. Cognitive behavior therapy, which is very common and easy to learn compared to the others, requires a focus on the long-term schemas or negative self-beliefs that fuel depression, the conditional beliefs such as if I don't do such and such, nobody will love me, that fuel emotionally driven behaviors, and automatic thoughts such as before walking into a test thinking, oh, I'm going to fail. By becoming aware of and reframing the negative and distorted cognitions, one can become less depressed, but the behavior part's also important, which is exposure to the events that have been mishandled and reprocessing them so that one can master them. Psychodynamic psychotherapy is beyond the scope of our talk, but deals with a more developmental, long-standing approach to the past episodes that have happened. And we'd say that in psychodynamic therapy, we're always looking at the relationship between how the patient related to people in their past, how they relate to people in their current life, and how they're relating to the therapist in the psychotherapeutic process. Behavioral activation is particularly exciting because it does not require a great deal of training or time, and it involves this. People who are depressed have a voice in them that says, why bother? They have difficulty getting motivated to do things, and they lose anticipatory pleasure. That is, when they think about something that would be pleasurable, they don't imagine that they'll enjoy it anymore. Therefore, they stop doing things that would have been pleasurable, that would have given them reinforcement. Behavioral activation, we work to get them on a schedule of doing activities and then measuring both the pleasure and the difficulty of the activity, and so they can be doing more and more. If they do the activity and it's pleasurable, it'll be reinforcing, and they'll be able to do more things. So if you don't imagine something pleasurable, and you sit at home all day and sit in bed, at the end of the day, not only if you had no pleasure, but there's a negative thought of, well, look at me, I didn't do anything. And then that next day, that fuels the why bother. If you do something, you believe you can do it again, that fuels an upward spiral.